From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, everyone. This is Paul Bryson from the Cleveland Clinic Department of Otolaryngology Head and Neck Surgery and your web editor for JAMA Oto. I'm pleased to join you today with Professor Reza Nouraei. He is the Professor of Laryngology and Clinical Informatics at Southampton University and is presently in Nottingham Forest in the United Kingdom. Welcome to the podcast.
Thank you, Paul. Thanks for having me.
Well, we'll get to talk today about a pretty cool and novel paper that you can look for in the journal. It's covering the topic and concept of the baroreflex sensitivity in patients with laryngopharyngeal dysfunction and the idea of this overwhelmed vagus hypothesis. So I wanted to commend you and the team on this publication.
Thank you very much.
Well, as we dive in, let's take the listener back a little bit. If you don't mind, just tell us a little bit about, what is the baroreflex and the concept of sensitivity, and then how does this vagus nerve and some of the things we see in the laryngopharynx, how does this all interact?
Sure. Baroreflex and baroreflex sensitivity are autonomic measures of heart and blood pressure control. So every time that we change our posture, so get up from the bed quickly, it's the baroreflex that stops us from falling over and having a vasovagal faint event. And it's particularly strong in humans who are upright primates. What it is that when blood pressure changes, so someone goes to a standing position and the distribution of blood changes, then heart rate adjusts itself so that blood pressure is maintained and perfusion to the key organs and particularly brain is maintained. It is an autonomic function and it is controlled by the glossopharyngeal and the vagus nerves, and of course the autonomic controller, which is distributed throughout the brainstem and sort of higher lower brain, as it were. So carotid and aortic arch baroreceptors are the primary organs that sense changes in pressure, send signal up mainly via the glossopharyngeal nerve in the case of the carotids. And the efferent loop of this is the vagus nerve, which alters heart rate and effectively maintains cardiac output in such a way that we maintain our blood pressure and don't keel over every time we stand up quickly. Sometimes we do, but on the main it does a great job. And the thing about baroreflex is that from minute to minute, unless it is problematic, like people with autonomic dysfunctions, diabetes, etc., you are not aware of it. But over a long period of time, if baroreflex function is reduced, so the system cannot control fluctuations in blood pressure, then it has a deleterious impact on the cardiovascular health and it increases the risk of a stroke and heart attacks significantly. In fact, baroreflex dysfunction, independently of other cardiovascular risk factors, increases the risk of a stroke and heart attack over a horizon of years.
So a very important reflex, one that we certainly maybe heard of in medical school and things like that. But as we think about its interplay and how it harmonizes in the pharynx, what's the bridge here between the autonomic function or bandwidth and maybe what we see in laryngology and otolaryngology in general? How does this connection, how does it lead us back to the glossopharyngeal and vagal functions that the listener might be familiar with?
Absolutely. Here is where it becomes an observation that needs both to be confirmed with other studies and looked into in other dimensions. But the basic premise of the overwhelmed vagus hypothesis goes like this. We know that the autonomic controller is one common space. The autonomic system, by definition, maintains multiple functions: the breathing, the heart rate, the GI system, the mood, several other things all together. So it always and all the time has to distribute the resources that it has to where it is needed most. And we know that even when someone is put on the tilt table, depending on which phase of tilt they are at, then the autonomic systems give different amounts of resources to the system. It's a very precious resource. Now, if we were to think about the throat is a very special place. It's the branchiovisceral junction, and it's also the aerodigestive junction. If you think of the GI tract as the visual system, that small part of the system is where the fovea centralis would be. That's where you need the highest amount of resolution because, one wrong mouthful could be quite significant if the system gets it wrong. Now, the other problem, not a problem because, it allows us to be communicating now, but one of the problems with the human aerodigestive system is that it has had profound adaptations late in the day in order to accommodate speech. So a lot of things like descent of the larynx, like some of the other changes that have happened, means that the system is not quite as good as it is perhaps in any other animal almost, in that aerodigestive function because it has to do more than one thing. It has become over-reliant on neurological control, and we've known that for a very long time. And when the signals that are generated in the throat are compromised, now whether that is the nerve endings that are affected by reflux, whether it's the abnormal contact between the mucosa from glottic atrophy or vocal paralysis, whether it is a named nerve neuropathy like we are seeing with COVID, the vagal neuropathies, the net effect is exactly the same. You're sending noisy signals up to the brain, upon which it has to make existential life and death decisions with every swallow that we make. And the way that most control systems, and that's not specific to autonomics, it's control system physiology more broadly, but the way that systems react to that is they distribute bandwidth where it is needed. So if you need a lot more of it in the throat, you have less of it going around somewhere else. You rob Peter to pay Paul. And that's why we think that patients who have pharyngolaryngeal dysfunction are having to their throat, the aerodigestive function consumes more autonomic energy from the brain, which means there is less of it available to less immediate functions like the baroreflex. And that's the overwhelmed vagus hypothesis. The throat overwhelms.
It seems very interesting, right? I don't know what your practice is like in the UK, but certainly post-viral neuropathies you mentioned, chronic refractory cough, all of the sensory phenomenon that a lot of us see after things as common as an intubation, an upper respiratory illness. A lot of things can change that neural microenvironment and feedback loop.
Absolutely. Absolutely. And by calling it laryngopharyngeal reflux, that constellation of symptoms, we've drawn attention to a very specific and very important cause. But perhaps in some ways we have looked for reflux as an explanation to all causes. And actually, although it is an important cause, it's not the only cause. In some ways, I think of reflux as nerve-ending neuropathy sending abnormal signals. But any other problem that interferes with normal signal transmission, a granuloma with an intubation potentially could do exactly the same, means that the throat isn't feeling right to the patient. So you get things like throat clearing as a way of sort of trying to get that sensory reassurance, coughing. And if the throat isn't right, and the throat is an important part, which both as laryngologists we believe it is, and I think the brain agrees, then it has to spend more time and energy on it to make sure that boluses don't go where they shouldn't. But it's a unifying way of thinking about all of those problems all at once, potentially.
Well, it's very fascinating, seeing these phenomenon in practice. I tend to agree. I think laryngopharyngeal reflux, while important, may not really be the full etiology for some of the phenomenon that we see. And I think it's important to entertain different etiologies and ideas that could help unify what we're seeing. As you look to the future, this paper being perhaps the first marker putting down this exploration, what's next for you and your group as you take this hypothesis and move forward?
What we've demonstrated is a potential association it is not a causality. And that would be where to think about next in terms of, first of all, replicating this work in other and larger studies. We did this study. It came about in a very pragmatic way, as opposed to something we sat on day one and planned. You wouldn't automatically think, let's look at Baroreflex in patients with LPR because we are bound to find something. It's an observation that we made as discovery, effectively. But having made it, now we need to prove it. And proving it in the context of a non-communicable disease requires demonstrating very specific criteria. And they are the so-called Bradford-Hill criteria. If you ask the question, does smoking cause lung cancer? One goes down the same path of demonstrating non-infectious causality. So we need to do more very specific work. So look at baroreflex function before and after either alginate or PPI treatment when we have a good basis in diagnosis that reflux actually is the problem. We need to look at the stability of things longitudinally, but also importantly, there are papers that suggest there is a link between gastroesophageal reflux disease and both pneumonia and gastroesophageal reflux disease and heart attacks from large epidemiological studies. Now, I don't know, I'm purely speculating, that an element of that may be related to that, but there are epidemiological linkage studies that can demonstrate that, and we are exploring ways of doing that. And of course, with LPR and reflux, I'm not discounting it as a cause of the problem. It's probably a very important cause of the problem, but we need to think about it more along the non-erosive reflux type problems with measures like mean nocturnal baseline impedance of the hypopharynx as opposed to acid exposure times, and try and understand correlation between measures of mucosal barrier integrity problem and LPR. And now with baroreflex, we potentially have a very sensitive quantitative metric that is A, prognostically significant, but B, if the hypothesis is correct, should quite nicely respond to our treatment. So I also see this as a potential outcome measure in clinical trials of trying to sort out this constellation of symptoms that we see so commonly in our patients.
Well, I certainly look forward to seeing what you find and seeing what the group finds. And I appreciate your time today. And I hope our listener will take a look at this manuscript, and congratulations. It's been great to have you on the podcast.
It is great being here. Thank you so much.
Well, I want to thank you for listening. I am Paul Bryson, and I've been speaking with Professor Reza Nouraei about the overwhelmed vagus hypothesis. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.